Moving on to our next speaker for the day. He is the founder of Dr. Gold Healthcare, India's one of the most known metabolic health and wellness center, with an epicenter in Coimbatore and others in Gobi, Erode, and Tirupur. He is a consultant laparoscopic surgeon as well and an expert researcher in reversing all chronic conditions like diabetes, hypertension, obesity, heart disease, fatty liver disease, GI diseases, PCOD, infertility, gout, autoimmune conditions like hypothyroid, psoriasis, RA, lupus, and significant improvement in the quality of life that he delivers to his patients and persons that visit him. He's also one of the most active members in the functional medicine group that sends testimonials of his patients on and off, and currently is running an academy as well for healthcare professionals, including nutritionists as well. He's also working in cancer and dementia without using any pills or drugs. And his current interest is in the field of longevity and integrating modern medicine science with the cutting edge of science and Asian wisdom in the uniqueness of his protocols. He is none other than Dr. Thangadurai RR. And his topic for today is why type 2 diabetes should be reversed. Thank you, sir, for joining us. And please go ahead with your presentation.
Thanks, Karishma, for the kind intro. I feel humbled and honored by this wonderful opportunity. And moving on to the topic, let me share this screen.
Yeah, I will. Just one second.
I will do it myself.
Yeah, you want me to share the screen or share it?
No, I will do it.
Yeah.
Yeah.
Can you please maximize?
So is it clear and audible there?
Yeah, it's clear and audible as well.
Right. So why should we reverse diabetes? As a general surgeon, if a diabetic patient comes with diabetic food, let it be cellulitis, necrotizing fasciitis, or gangrene, it's the emergency life-saving procedure to do the wound debridement or fasciotomy or amputations. Are we doing it right? Are we really improving the quality of life afterwards? The answer is no. Because in conventional science, type 2 diabetes till today is considered to be chronic and progressive. It's only a matter of time. The patients will end up with a lot of complications, even when we use a lot of drugs or insulin. When I researched into the field of metabolic health, I found a ton of research articles that has not been translated into clinical science, which means there are tons of research articles already available, but they have not been translated into guidelines and protocols so that we can implement in our clinical practice. So what I have done is, the last 6 to 7 years, have done this translation of researchers into clinical practice. It helped us a lot to bring about life-changing transformation in patients' life. Living well with diabetes, it's a perfect example for oxymoron, because the patient will develop a lot of complications over a period of time, even when we use a lot of drugs or insulin. So what are the complications of diabetes? Let it be macrovascular like heart attack, strokes, and peripheral artery disease, or microvascular complications like neuropathy, nephropathy, retinopathy, and all those things. The problem is, the sales pitch from the drug industry is, we know this very well, that it decreases the microvascular complications, that is the morbidity, at the expense of what? Increasing the macrovascular complication that leads to mortality. The most common cause of death in diabetic patients, more than 60%, is attributed by cardiovascular causes, let it be heart attacks or stroke. Of course, diabetic drugs lower blood sugar numbers, but we are paying a price for it. It actually accelerates the disease process and kills type 2 diabetic patients earlier. All these 6 major trials indicate that when we intensively control glucose by aggressive treatment using a lot of drugs or insulin, the cardiovascular events and the mortality increased to our surprise. So the American College of Physicians has set a guidelines with the goal of achieving HbA1c to between 7 to 8 instead of intensively controlling it between 6 to 6.5. Let's see what happened in the ACCORD trial. Patients with HbA1c of on an average of 8 was taken into account, And there are two arms: standard treatment to achieve a goal of HbA1c between 7 to 7.9, and intensive arm in which the goal was set to decrease the HbA1c on an average of HbA1c 6. To our surprise, the intense arm died more, which means the patients who had undergone the intensive therapy with a lot of drugs or insulin died more. This is not the usual expectation, right? We expect when we control insulin within the limits, we want the patients to live long. That is what is the normal expectation. But the result was exactly opposite. This is what we call the Accord paradox. Is it a paradox? Let's see. The Accord trial, patients who are in the standard arm were taking 50% insulin. I mean, 50% of the patients on the standard arm were on insulin, whereas in the intensive arm, over 75% of the population in the standard arm, in the intensive arm, were on insulin. And this is due to this insulin toxicity and hyperinsulinemia. The cardiovascular events increased, and this produces excess deaths. So I would say that when we see a roadmap of type 2 diabetics, even before the diagnosis of type 2 diabetes, for about 10 to 15 years time, a person suffers from insulin toxicity. And after diagnosis, what we are doing? We are treating them with insulin secretagogues or insulin, which means we are again raising the insulin toxicity. This is actually a wrong term. By using insulin secretagogues and insulin injections, which may give you a false sense of security to the patients by controlling the glucose numbers, but it is not true because there is no significant evidence of long-term efficacy of insulin on any clinical outcome in type 2 diabetes. Okay, so what this insulin therapy does to our body, when you are using more and more insulin, it increases the insulin resistance. Also, when we increase the dose of insulin, many of you would have been wondering why the patient is not losing weight. Perhaps the most important advice, what we give it to the patient is lose 10% body weight. It will not happen when you are using insulin secretagogues or insulin, because insulin is a fat storage hormone. When we are increasing insulin, what happens? It increases fat gain. And also, it decreases the basal metabolic rate, particularly the basal insulin. And this contributes to increased percentage of body fat. It also increases the cardiovascular mortality. Why? Because we all know that hyperinsulinemia is a predictive factor for coronary artery disease. And there is high association of sulfonylureas or basal insulin with cardiovascular risk. Surprisingly, it increases cancer mortality. But why? We know that insulin is not only a hormone that regulates cellular metabolism, it also regulates cellular growth and proliferation. Of course, high insulin level is actually a growth factor. And when you're using a lot of insulin, what happens? It promotes cancer growth and it can produce increased cancer mortality. Reason why obesity is risk factor for many of the endodermal cancers is because of the basal hyperinsulinemia, because most of the obese individuals will be having basal hyperinsulinemia, and this will cause endodermal cancers to rise. The endodermal cancers like thyroid, breast, gallbladder, liver, pancreas, stomach, rectum, kidneys, uterus and ovaries. So when we look at the natural history of type 2 diabetic patients, 10 to 15 years before a person is being diagnosed with diabetes, he suffers from insulin toxicity. He suffers from insulin resistance. This is the missing link. We are not looking at a patient, measuring the fasting insulin level. We are picking the patient very, very late. That's a negligence, I would say. And only after so many years of diabetes, the insulin starts decreasing. And only in the very late stage, there is low insulin secretion. But otherwise, in 80 to 90% of the patients with type 2 diabetes have high insulin secretion or normal insulin secretion. So type 2 diabetes is not a disease of insulin insufficiency, but it's a disease of insulin inefficiency. Okay. So what is the difference between insulin sensitive person and an insulin resistant person eating the same meal, like 3 times a day and along with snacking? Insulin sensitive person, in insulin sensitive person, he can achieve the basal insulin level, but an insulin resistant person will not achieve the basal insulin level. Perhaps the insulin will be elevated throughout the day, and this constant elevation will cause downregulation of insulin receptors. And this downregulation of insulin receptors leads to insulin resistance again, and it's a vicious cycle. So what we are really doing in conventional science, we are looking at the high blood sugar numbers as a disease. It's not a disease. Perhaps it is only the symptom. What is the disease? Insulin resistance is the disease, and high insulin levels or hyperinsulinemia is both the horse and the cart, which is the cause and the consequence of insulin resistance. So what is the real problem? High insulin or high glucose? I would say the insulin toxicity that occurs prior to the diagnosis of diabetes is what is driving the disease. We mistook the symptom, that is the high glucose, as the disease. What makes more sense? Lowering insulin by changing diet, or else lowering glucose by giving more insulin. Why we became insulin resistant in the first place? Because you have overstuffed your adipocytes. The adipocytes can expand up to 20 times its normal size and 8,000 times its volume. But when this limit is reached, then the insulin is having a hard time to push the fat inside these adipocytes. And this is where the insulin resistance occurs and the insulin level starts to rise. So when we look at the roadmap of type 2 diabetes, when a person is washed up with fat cells, what happens? He loses his metabolic flexibility and he becomes metabolically inflexible. Then excess lipids will stay in the circulation because there is no room to go to get deposited in the adipocytes. Where are the adipocytes present? The adipocytes is present in the subcutaneous space between the skin and the muscles from head to toe. But when the capacity is overwhelmed, what happens? The patient will leak a lot of free fatty acids, lipids, in the circulation. This is what we call the dyslipidemia. So dyslipidemia is nothing but pre-diabetes. And over a period of 10 to 15 years time, a person develops pre-diabetes in which the sugar number starts to rise. And in about 2 to 5 years time, he becomes diabetic, during which there are a lot of sugars inside the blood, a lot of lipids inside the blood. So this picture is so important for you to understand what is really happening with type 2 diabetes. In conventional science, what we are doing, we are looking at the consequence of the disease, that is high glucose. We have to dive deep into the ocean to look at the base of the iceberg. But what we are doing, we are looking only at the tip of the iceberg. What really happens inside the base is what reveals the roots of the disease. So this, I have already mentioned that a person can store a lot of fat inside the subcutaneous space. But when the subcutaneous space is overfilled, the personal fat threshold is reached. And during this time, all the fat will get deposited in the visceral space. And after that, it circulates throughout the body into the systemic circulation. This is where it gets deposited as ectopic fat in the liver, muscle, pancreas, producing fatty liver, fatty muscle, fatty pancreas, which are the roots of high glucose numbers. Without this, high glucose numbers will not rise, right? So we have looked at what is the cause, but we are simply looking at the consequence of the disease. There is an alternate pathway, what I call usually the ultra processed food bypass. Even without reaching the personal fat threshold, one can become diabetic. Most of the patients today are becoming diabetic in this way. That is consuming excess refined carbohydrates, refined sugars, and refined oils that can lead directly to fatty liver and fatty pancreas and fatty muscles, which again leads to diabetes. So there is dyslipidemia that precedes dysglycemia. This is what we need to understand. We cannot reverse diabetes if we keep on treating only the glucose. Perhaps what we need to treat is the dyslipidemia, which is based on the insulin-centric model. And the insulin stays high most of the time, only in the late phase of type 2 diabetics, that is 5 to 10% of the cases, the insulin is low. So type 2 diabetes is a combination of dyslipidemia and dysglycemia. Insulin resistance is primarily a problem in the lipid metabolism. Many of you would have thought that it's a primary metabolic defect in the carbohydrate. It is not so. Governed by personal fat threshold, body composition, and liver health. Dyslipidemia occurs early in the spectrum of insulin resistance. Dysglycemia occurs very late. And dyslipidemia always precedes dysglycemia. Conventional medicine centers around correction of dysglycemia, but worsens dyslipidemia mostly. So what we are doing in conventional science, we're using a lot of drugs and insulin, or we don't even bother about the food that we take, so that the disease progresses pretty quick in the stage of high insulin levels. If you want to reverse the diabetes, we have to fast. We have to lower the insulin down by eating the real food, because type 2 diabetes is a disease of too much insulin and not a disease of too much glucose in the first place. For example, this is a classical example of a prescription in the conventional science. See, the patient is prescribed 90 units of insulin, exogenous insulin, along with high dose of insulin secretagogues. Are we doing it right? Perhaps not, because the patient may die early with great looking glucose numbers because of the macrovascular complications, and death can happen by giving high dose of insulin. So how to go about it? We have to eat the real food, that is the low insulin diet, which is a combination of low sugars and high fiber, so that we reduce the insulin levels, we reduce the insulin resistance, and defat the lipotoxicity. What is lipotoxicity? It's nothing but the deposition of fat inside the liver, muscle, and pancreas. Under low insulin diet, we can defat the lipotoxicity, that is converting the fatty liver, fatty muscles, and fatty pancreas into normalcy, thereby regaining the insulin sensitivity. So what we need to do is, we need to decrease the insulin levels first, insulin resistance, which warrants glucose control. So the glucocentric model is not the right way. Perhaps the insulin-centric model, by lowering the insulin resistance, by eating the real food, could be the right way. So we have to be little cautious using insulin or sulfonylureas and meglitinides, which increases the insulin in our body. Perhaps these should be reserved only for patients who are having low fasting insulin, low insulin reserve. That can be reserved for about 10% of the cases most of the time. Rest 80 to 90% of the time, we can reverse insulin resistance and diabetes completely. So what is the problem with exogenous insulin? Liver is the first organ to receive insulin from pancreas. But when you're giving exogenous insulin subcutaneously, it reaches the systemic circulation first, and then it reaches this splanchnic circulation. And it fails to inhibit the glucagon production in the alpha cells of pancreas, and its action in the liver to decrease the endogenous production of glucose. So the real villain is ultra-processed food. Again, is a combination of excess sugars, refined oils, and refined fats, which produces a vicious cycle of excess body fat, chronic inflammation, and insulin resistance, which predisposes to all the risk factors like increased triglycerides, decreased HDL, increased fasting glucose, BP, and high waist circumference, which leads to all the modern illness that we are suffering, range from heart attacks, strokes, gout, gallbladder disease, cancers, and whatnot. So we have to treat the roots of the disease which is high insulin level and insulin resistance. So what we are supposed to do, we had to decrease or eliminate the ultra processed food, which is again a combination of excess sugars, refined oils, refined fats, refined carbohydrates. To decrease the insulin level, and under low insulin level, what happens? The fat burning mode will be there, and it will actually preferentially burn the visceral fat and fat inside the liver, muscle, and pancreas before it takes the subcutaneous fat, thereby reducing the insulin resistance, and these organs starts functioning well, and there will be reduction in all these risk factors, and we can regain metabolic health. There is a caveat in diabetes remission definition. The latest definition for diabetes remission is to achieve a HbA1c of less than 6.5 for a period of 3 months with or without metformin. But the problem is the patient may still suffer from pre-diabetes and can be in the insulin toxicity, as well as he may suffer from all the complications related to pre-diabetes. So this definition is actually suboptimal. So the reversal of diabetes is not reversal of insulin resistance. This is what we need to understand, because reversal of, insulin resistance is a huge spectrum. Diabetes is only the latent of the insulin resistance spectrum, right? So reversal of diabetes is only centering on euglycemia, that is achieving normal glucose numbers, whereas reversal of insulin resistance centers around achieving eulipidemia, that is your triglycerides should be normal, your HDL should be normal, triglyceride HDL ratio should be normal, and fasting insulin should be normal. This is what we have to focus. So why diabetes reversal itself is not enough? Because when a person is diagnosed with diabetes, he is having high insulin level. And when you're treating the diabetes with a lot of drugs or insulin, he suffers again from insulin toxicity. Let it be diabetic reversal. When we look at only the glucose numbers, the patient may be at point D, point C, or point B, where the person still suffers from insulin resistance or high insulin levels or dyslipidemia. This should be your take-home message. And we have to achieve complete reversal of insulin resistance. And the goal should be to achieve a fasting insulin of less than 6 and a triglyceride HDL ratio of less than 1.3. This should be your target, not just achieving normal glucose numbers. Because the person in the insulin toxicity, when a person is suffering from dyslipidemia, atherogenic dyslipidemia, or insulin resistance, or hyperinsulinemia, what happens? He is bound to develop all other consequences of insulin resistance, ranging from high BP, high cholesterol, heart disease, obesity, fatty liver, gout, PCOS, infertility, dementia, and cancers. So what we are supposed to do? Had to eliminate the ultra-processed foods. We had to stay well below the personal fat threshold by having a very good muscle mass, lean body mass, and less fat mass, so that we can stay in the safe zone of metabolic flexibility. Okay, stay in the zone of metabolic flexibility. You will never develop diabetes in your life. Okay, it's not about genetics. It's about our lifestyle. It's about the food, what you eat, that determines everything. It's about epigenetics. It's in your hands, right? So you have to prevent the formation of fatty liver, fatty muscles, and fatty pancreas. Without these, diabetes cannot occur. Okay, so when you're keeping your levels below PFT, that is the threshold limits, what happens? You are fantastically insulin sensitive. Your fasting insulin will be like less than 6, less than 4. Your triglyceride HDL ratio will be less than 1.5, and you will be doing wonders. You will not suffer from any of the chronic diseases which I have mentioned here. You are not bound to suffer from any of these chronic conditions. Take it from me. So the words of wisdom is, we have to reverse diabetes to stay away from all the complications like macro and microvascular complications. But it is not enough to achieve diabetes remission alone, but it is highly, highly, highly imperative to reverse insulin resistance completely in order to negate all the manifestations of insulin resistance. Perhaps 75% of this healthcare nowadays is contributed by insulin resistance alone. So, what could be our conclusion? Diabetes is a very late manifestation of insulin resistance. Insulin resistance is present for years before diabetes is diagnosed, maybe for 10 years, 15 years, 20 years down the lane. We should redefine diabetes to be diagnosed when insulin levels and triglyceride HDL ratio starts to rise, which means we should also redefine the diabetic remission definition itself. The best way to treat diabetes is to adapt to the low insulin diet, which is a combination of high fiber and low sugar, to reduce the ectopic fat by lowering the basal insulin levels and to restore the first phase of insulin secretion. So what could be our aim of reversing diabetes? To prevent the complications of diabetes and insulin resistance altogether. I would say it is highly unethical to deny or even delay remission of type 2 diabetes, because we are living in the era of disease reversal, disease prevention, and we should not stay in the era of just maintaining the signs and symptoms. I mean, just addressing the symptoms of the disease. Perhaps we have to address the roots of the disease, and there should be a paradigm shift from illness to wellness. Okay. Let me share this video clipping. There is a lot of debate. What is whether low insulin diet or low carb diet or low fat diet? So there is a lot of debate going on between low fat and low carb. Is it not? And actually, there are a lot of discrepancy around it. Unless it is fixed, we don't have enough knowledge to reverse insulin resistance completely. Let me share this clipping. Hope you enjoy this.
We cannot hear the audio. Does the video have an audio?
Yeah, of course. Just a minute.
Okay, please. Please play again, sir.
Yeah, sure. Then let me share the screen again.
Yes.
Is it clear there?
Can you please start the video?
Right.
Fine, the audio is not there. There's some issue.
Okay, let me give a commentary. So there is a lot of dietary battle going on between the low carb and the low fat. Usually low carb actually promotes the model because they firmly believe that most of the diseases of modern era associated with insulin resistance is due to the carbohydrate insulin hypothesis, right? But low fat vegan promotes what we call the whole food plant-based diet, because it firmly believes the diet fat hypothesis and the cholesterol hypothesis. The basic issue here. So there are a lot of debates going on between the low carb and the low fat, and we are actually fighting the wrong battle, I would say. Both are backed up by science, to be honest, but we don't know the real truth. What could be the real truth? Both the diets may not be mutually exclusive, but they could be mutually inclusive. That means if they involve the real food, which is low in sugar and high in fibers, it encompasses both low carb and low fat. So what we are supposed to do, we have to fight the ultra processed foods, which is a combination of excess sugars, excess refined vegetable oils, and refined fats, that way knocking out the ultra processed foods. And that is where the foundation of wellness lies. Thank you for the wonderful, wonderful opportunity and your patient listening. Thank you all.
Thank you so much, sir. That's Mr. and Mrs. Smith presentation from your side. Thank you so much for making the audience understand. There's one question that I'd like to ask, and rest of them you can answer in the chat box. Multi-drug trials show that the GLUT2 inhibitors play significant role in cardiovascular risk reduction as well as renal protection. Any takes on it?
That's only a marginal increase because it has been boomed up because of the relative risk. It's only giving the relative risk. It's not giving the absolute risk reduction. It's only a marginal risk. Perhaps you can use it because it is having a marginal risk, but it is not the optimal treatment. Perhaps you had to reverse the insulin resistance completely and get the patient back to wellness.
Yes. Thank you so much, sir. A lot of feedbacks for you as well for a very nice presentation, interesting presentation as well. Please stay back. I request you to stay back and answer the questions in the chat box. Thank you so much for joining us.
Thank you.